at Manchester University Hospital, and I'm a professor of pathology at Manchester University. So, just a couple of kind of like pointers. First of all, Niels Bohr, who won the Nobel Prize for physics, said that an expert is a person who's made all the mistakes that can be made in a very narrow field. So, by that definition, I'm not an expert. It's always important to remember that we learn every day and see new things every day. Guard against mistakes and learn from our mistakes. So why do I show this picture of where is Wally? Because Trophine pathology really is at the interface between cytology and morphology. So most of histopathology is very morphology based and pattern based. And then, of course, cytology is just the details of the individual cells. Bone marrow pathology is looking at the detail of the different cells and the pattern of the cells. They're both very important. And you kind of like put those two together to synthesize the whole picture. So in terms of bone marrow examination, I kind of like break it down into different areas. Some people just give a big text, but I look at certain different break it down into subgroups of things that I'm going to look at. And that can make a more complex picture simpler because I've got a simple mind, so I break down everything as simply as possible. So first of all, look at the Trophine biopsy in terms of its length, the number of marrow spaces there. Is it adequate for diagnostic purposes? And by that, is it adequate for the diagnostic purpose that is being asked of it? So, for instance, diagnostic purpose for query myeloma or lymphoma, that can be patchy, so you need a good quality Trophine. Is it kind of like acute myeloid leukemia or recurrent acute myeloid leukemia? Well, even if you've just got 2 marrow spaces and they're full of blasts, it is adequate for diagnostic purpose. So it's important to state the adequacy with relevance to the clinical question. I always look at the bony trabeculae. Are they thinned? Are they thickened, which is important in myelofibrosis? Are there lots of cement reversal lines, which is an indicator of multiple rounds of chemotherapy, and so on? And then look at the cellularity. So the cellularity of the marrow, in terms of how much the marrow is occupied by hematopoietic tissue, should be approximately 100 minus the age of the patient. So the cellularity in someone aged 80 is going to be about 20. Someone aged 20 is going to be about 80. There's very wide error bars on that, but it has the cellularity dropped. After treatment, after chemotherapy, the cellularity can be very variable as different clones kind of like regrow in the marrow. So only once I've done all that, I look at the different lineages, the erythroid, the myeloid, and the megakaryocytic lineage, and then any other cells, specifically plasma cells, lymphoid cells, eosinophils. And the most important thing in all bone marrow pathology is what is the clinical features and what is the aspirate show. So in many instances, our job is redundant because the job's been done for us by the hematologists. But sometimes the aspirate doesn't work, or it's an aparticular aspirate, and so it's down to us. So probably more than any other branch of pathology, the clinical correlation is absolutely vital because different clinical scenarios can produce a similar morphological picture. So information and communication is vital. So this, apocryphal kind of image from the First World War, the first soldier said, send reinforcements, we're going to advance. By the time it got down the line, came out as send 3 and 4pence, we're going to advance. So communication, and getting all the information together is absolutely key. That's why bone marrow biopsies all kind of justify the highest RC path workload points because each one of them is quite complex. But I'll try to simplify them down. So I've got 7 cases. I will go through them relatively rapidly, but you have got the slides to look at, and this presentation is already up on the Smarty Media site. And what I will do is I will cover the areas that might be expected in the exam. It's fair to say I don't think you'll get anything difficult if you do get a Trophine in the exam, because to get something difficult, we'd have to give you so much clinical information that you probably wouldn't need to look at the biopsy. So case 1. It's a 78-year-old male. He was admitted with a raised immunoglobulin and with renal failure, and it was query myeloma and query amyloid. So let's look at the slides. So this is the H&E. You can see that it's a nice adequate trephine, probably about 1, 2, 3, 4, maybe 5 marrow spaces. I think it's adequate for purpose. Interestingly, even at this low power, you can see an area of slightly hypercellular, that area. So it's good to focus in on that area. So you can see that you've got loss of some of the fat spaces here, and we have got a collection of small cells. Now, plasma cells, they're described as having a clock-face nucleus. I've never really seen that convincingly. What you're looking for is cells with an eccentric nucleus. So that's got an eccentric nucleus there. I think that, by association, a lot of these others have got an eccentric nucleus. But the most important thing, if you're considering a myeloma, is to go straight to the immuno. So we do an awful lot of immuno in Haempath, and the hematologists won't believe us unless we do the immunos. So these are the immunos that were provided. So a CD138 can be a bit of a dirty stain. It stains epithelial cells as well. That's the control. So here it is. And what we're looking for is nice cytoplasmic staining. So all these cells are probable plasma cells or plasmacytoid differentiation. Of course, there may be epithelial cells, but we're kind of like, hopefully, they're not epithelial cells. It doesn't look like carcinoma anyway. But if you see a 138 positivity, you've always got to consider that possibility until you look at the MUM1 as well. So MUM1 is a more specific plasma cell marker. And from this, you can see this is a nuclear marker, and you can estimate the percentage. And it's important to estimate the percentage across the entire trephine, maybe commenting that some areas are more densely packed than others. And the percentage you're going to estimate with the MUM1 is always going to be less than with the CD138, because the CD138 obviously covers a larger area because it's cytoplasmic, and so your eyes think that it's a higher percentage. In this patient, the plasma cells accounted for about 90% of the cells present. You then look at the light chains. So it's important to remember that the normal serum has got light chains in it, so there will always be a little bit of background staining for whatever is the non-restricted light chain. So here we've got kappa, and it's always important to see at least a few positive cells, residual cells like that there, and always check the control. Always check the control with kappa and lambda. Otherwise, you've got the possibility of being caught out and saying something's restricted when the other one just hasn't worked. And that is something that does happen very occasionally. It's not happened to me for many, many years, and it was detected immediately. So lambda, strong lambda staining, and what you're looking for is cytoplasmic staining. I'm sorry this one didn't scan quite as well, but you can see that we've got cytoplasmic staining rather than this background serum staining, which is what you've got to ignore, because of course there is staining in the serum as well. There are light chains in the serum, and so that will stain. Okay, now we're going to go on to case 2. So just to say a couple of things about myeloma. The WHO has a whole list of plasma cell neoplasms, solitary plasmacytoma. And then in terms of what you're really interested in, is it smoldering myeloma? Is it a monoclonal gammopathy of uncertain significance, which is actually not in this table anymore, but essentially should be? Or is it a plasma cell myeloma, or is it full-blown myeloma? And there are criteria for that, and these are those criteria. So to call something multiple myeloma, you have to have at least 10% clonal plasma cells with light chain restriction and one of the following. So hypercalcemia, renal insufficiency, anemia, or a bone lesion. So some end organ damage or myeloma. Or if you've got more than 60% plasma cells involved, even without these features, even without clinical features, then it becomes myeloma. So you can call it plasma cell myeloma or a monoclonal gammopathy of uncertain significance if it's less than 10% plasma cells, no clinical end organ features. But in between a monoclonal gammopathy of uncertain significance and myeloma, I call it a plasma cell dyscrasia. And then the clinicians can decide if these other features are present, whether to call it myeloma or not. Right, quickly on to case 2. So case 2, we've got a long core here of blood clots, so I'll ignore that. But we've otherwise got a very nice core of bone marrow. And you can see the bone is sclerotic. It's irregular. There's focal woven bone in places. So we've obviously got osteosclerosis. And when you look at the marrow, the cellularity is maybe a little bit reduced. This is a patient in their 60s. And even at this power, we can see lots of atypical megakaryocytes, which are forming clusters in places. There's a little bit of expanded myelopoiesis as well, with some eosinophilia. This is a myeloproliferative neoplasm, specifically myelofibrosis. And the myeloproliferative neoplasms often have some eosinophilia. The important thing also is you get this streaming of the cells along lines of fibrosis. So this is a clear case of myelofibrosis. Myelofibrosis can be primary or secondary. It can be secondary to essential thrombocythemia. You can also get pre-fibrotic and cellular phase myelofibrosis, but this is clearly fibrotic. The key feature is the atypical clustered megakaryocytes. And also in the fibrotic stage, this clear collagen fibrosis. In order to see collagen fibrosis, you have to do a reticulin stain, and the reticulin stain should be counterstained with a trichrome, because the reticulin fibers will only stain, well, it's a silver stain which just stains reticulin. To see collagen, you need a collagen trichrome stain. So this is elastic Van Giesen. So here we've got purple staining of elastic Van Giesen, and this is grade 3 fibrosis in the WHO, grade 3 increased reticulin in the WHO classification. It would be grade 4 in the Bowmaster stage, but nowadays we use the WHO classification. If you really need to have grade 3 with collagen fibrosis to call it myelofibrosis, unless you've got the cellular pre-fibrotic phase, but then you need other clinical features to make the diagnosis. Can use a CD61 to highlight the megakaryocytes, and you can see here nice clusters of megakaryocytes. You can even get clusters within the sinusoids as well, and lots of platelet fragments. So large, bizarre clusters of megakaryocytes. The other thing you get clusters of megakaryocytes in is you can get occasional clusters in myelodysplasia, but that's not difficult to diagnose because it's a pancytopenia, or in essential thrombocythemia. But in essential thrombocythemia, the clusters of megakaryocytes are smaller and the cells are less bizarre, and we'll see a case of that as we go along. Okay, so just to say a couple of things about myelofibrosis, and again, this information is available for you to look at already on the system. So it's always important to consider in bone marrow, are we dealing with a myeloproliferative neoplasm? And if it is, it's going to be either primary myelofibrosis, which will look like this with clear fibrosis, and a reticulin stain will always be given in the exam. They will always give the full blood count as well. So if the white cell count is very high and you've got a range of myeloid cells, and it's chronic myeloid leukemia. If you've got a high hemoglobin, then it's a polycythemia. And if you've got high platelets, it's essential thrombocythemia. They are unlikely to give you any of these in the exam. Maybe a mastocytosis, which would be accompanied with a Giemsa stain or a CD117 stain. But generally, if they give you a myeloproliferative neoplasm, it'll be one of these. And the important thing is always to look at the full blood count before you look at the trophine. There are the criteria there, which I've reproduced for you. This highlights the importance of molecular for the diagnosis of these diseases, but the diagnosis can be made without molecular with a correlate with a combination of morphological and clinical features. And this is just to indicate that primary myelofibrosis can often start off with a diffuse hypercellular form, moving into a hypocellular fibrosic form. And this shows the WHO grading, which I've highlighted for you in this presentation. And that it starts off often with a pre-fibrotic phase and then moves to a fibrosing phase. So case 3 just highlights, I'm just going to go over through case 3 quickly, because case 3 is something you're not likely to get in the exam, in fact. So probably ask, why on earth did I put it in then? That's a very good question. This is a case of chronic myelomonocytic leukemia. This is defined by a high monocyte count with at least 10% of the white cells being monocytes. And it's an overlap between a myeloproliferative and a myelodysplastic condition. So we've got some dysplastic features in here as well as proliferative features. The proliferative features are reflected in the full blood count. So we've got a monocytosis and a high white cell count. So that's how you see the proliferative features of the myeloproliferative disorders. Have they increased the white cell count, the full blood, the red blood cell count, or the platelet count? And then morphologically, we've got dysplastic features, which we'll also look at later on when we look at the myelodysplasias. We've got atypical megakaryocytes. We've got focal micromegakaryocytes. We've obviously got left-shifted myeloid cells. We've got disrupted erythroid islands. So we have dysplastic features in here, as well as proliferative features of the full blood count. And that puts it into the category of a myelodysplastic myeloproliferative overlap syndrome, of which the most common is chronic myelomonocytic leukemia. It's a diagnosis that can only be made by a combination of the morphology on the trephine and the aspirate, and in the trephine you get this jumbled up morphology of broken up erythroid islands, scattered myeloid cells at all stages of differentiation, quite a lot of left-shifted and immature myeloid cells, an increased number of megakaryocytes, micromegakaryocytes such as here, focal clusters of megakaryocytes, so those are all dysplastic features, and the combination together is a chronic myelomonocytic leukemia. Sometimes they are associated with another hematological malignancy. So this area here is suspicious for mast cells. I haven't got the immuno for that, but you can get systemic mastocytosis with an associated hematological neoplasm, and chronic myelomonocytic leukemia is often the other associated neoplasm with systemic mastocytosis in that instance. So move on to case 4. So I'm really trying to give you an overview of all the possible kind of scenarios that you might get in Haempath and Trephines in just one lecture. So bear with me. This just shows the fact that you've got these, you've got either the myelodysplastic lesions or the myeloproliferative disorders, and then you've got this overlap in the middle of myeloproliferative, myelodysplastic, including chronic myelomonocytic leukemia. I don't think you're likely to get that in the exam, though. If you do, it'll be because there's a high monocytosis in the full blood count. And again, it means that you don't really need to look at the marrow, so they probably won't give it to you. Right, case 4, 24-year-old male, previously fit and well, 5-week history of infections, fatigue, gum bleeding, and a high white cell count. So the diagnosis, you pretty much don't need to look at the slide to see the diagnosis. This is an acute leukemia, rapid onset, and there we have an example of how we would write the report. So let's look at the sides. So here we have a very good trephine biopsy. Very adequate. And you can see also instantly at this power that it's almost maximally hypercellular. Lost all mostly the paratrabecular fat spaces are mostly lost. It's filled in with a proliferation. And when you look at higher power, most of the cells look the same. So we haven't got that range of cells that we had in the previous biopsy. All of these, a uniform population of cells. So the myeloproliferative disorders, even if they're hypercellular, will have a range of different cells in there. In chronic myeloid leukemia, you'll have immature forms, maturing forms, and mature neutrophils. If you've got all the cells looking the same, and it's the same all the way through the biopsy, then it's going to be an acute leukemia. The only other instance where all the cells are the same is that it's all the cells are the same in an area, but then you've got some normal hematopoiesis elsewhere, and that's what you'd see in a lymphoma. But an acute leukemia will pretty much fill the entire marrow, and certainly one that you get in the exam, you'd see the same cells everywhere you look, the same in all directions. The main cell that might persist in this onslaught from a proliferative collection of blasts is the megakaryocytes. And so the question is, what are these blasts? Well, Barbara Bain in her book spends about a page and a half saying how you can use the morphology to distinguish them, and then ends with a sentence that morphology is unreliable and you need to use immunos. So if the cells have a more fascicular chromatin, and if they've got a more prominent nucleolus, and if they're more uniform in shape, I mean, these all look the same, but there's a slight lack of uniformity between them. If those are the case, then it's acute. It's more likely to be acute lymphoblastic. But in this case, you've got indistinct nucleoli, kind of clumped or stippled chromatin. The cells look slightly different from each other. It's more likely to be acute myeloid leukemia, but you can only really decide that based on the immunos, both on the flow cytometry and the immunohistochemistry. I'll just pass over the retic for that one. Sorry. So we can do myeloperoxidase. And this one was strongly myeloperoxidase positive. It's important to realize that cases can be myeloperoxidase positive on the trophine and negative on flow cytometry. And to make a diagnosis of a biphenotypic leukemia or ambiguous lineage leukemia, you have to have it myeloperoxidase positive on the flow and not just the trophine. So this was strongly positive for myeloperoxidase. Also positive for CD34, which is a very granular stain, so you have to look carefully in to see it. And it was also positive for 117. It's important to realize that 117 can also be positive in mast cells. So we have some isolated little mast cells here, and also positive in erythroid cells, immature erythroid cells. But there aren't any erythroid cells here, as demonstrated by the cadherin, which is a separate slide I've not shown you. But you can see here we've got 117 positivity. So that's three myeloid markers positive. In terms of how we the markers that we use for these, I'll just show you those. So the markers I would use are myeloperoxidase, CD33, 34, 117, and then I would also put in the lymphoid markers, so CD3, 20, 79A, TD10, and TDT. So I'd also put all of those in case you're dealing with an ambiguous lineage leukemia. And then acute lymphoblastic leukemia, most of them are B. They'll be positive for CD10 and TDT. As I've said, the cells are more uniform, more prominent nucleoli and clear chromatin. But despite this, immuno alone is diagnostic for those. So now I'll go on to case 5. So case 5 is from a 52-year-old man. The history I had, which makes it slightly easier, is that there was a previous history of follicular lymphoma. I'm not sure I put that in for you to make it so that it wasn't too easy. So even at low power, you can see here for 52, it's maybe slightly hypercellular. And if you get a slight increase in cellularity, you've got to wonder what's causing that? What's tickling up the marrow? What's going on in the background? And then you've got these areas there, and there. Now, some of these are paratrabecular, like that one, and that one there. Some are intertrabecular, like this one here. If you've got a paratrabecular lymphoid aggregate, certainly if you've got 2, but probably if you've even just got 1, it's almost always going to be lymphoma. So if you see any paratrabecular lymphoid aggregate, and it might be focal, so you have to look carefully through the whole biopsy, then it's going to be a lymphoma. Okay, and you can see here, in contrast to the AML, that you've got normal hematopoiesis or reactive hematopoiesis distinct from the infiltrate, whereas in the acute leukemia, it was everywhere. The change was everywhere. So then it's a matter of looking in to see what the cells are like. Now, using morphology to try and see what the cells are like is very difficult and kind of unreliable, really. Here we have a mixture of some larger cells, some smaller cells. Now, this I know is follicular lymphoma, but because of the way the fixation happens within the trephine and decalcification and so on, then seeing the classical kind of features that you see in follicular lymphoma in a lymph node, you're not going to see in a trephine. All you're going to get is there some variety of the cells? Yes. Some of them look a bit centrocytic, some of them look a bit centroblastic. Sometimes if it's something like chronic lymphocytic leukemia or mantle cell lymphoma, I saw a case of that this morning, then you'll just get them all small and uniform. But really, it's a matter of putting it together with the clinical history and with the immunos. So it's also important to look to see if there's any areas of transformation, focal blasts, and you have to look through the entire trephine because that might be focal. It's also important to try and estimate what percentage of the trephine is involved. Now, this is going to be under 5%, I would say, certainly well under 10%. Because then when you treat the patient, if the percentage, you want to see the percentage go down. So looking into this area here, we do have some slightly elongated centrocyte-like cells. We have got some larger centroblast-like cells, but as I say, the morphology of this, using morphology alone, is rather, it points to it, but it's not hard and fast. Some people say that follicular lymphoma is more likely to produce a paratrabecular aggregate than the other lymphomas. Well, that may be true, but the other lymphomas can still do it. So if you do get a lymphoma, it's likely to have a paratrabecular aggregate because that is hard and fast a lymphoma. Virtually nothing else will cause that. Looking at the immunos for this case, the retic can be helpful because it can point out the areas and highlight the areas. So you can see the retic is condensed around these areas. So you can use the retic to find small focal areas of infiltration that are difficult to see on the H&E. CD20 is really useful, and you can see them highlighted really nicely here. It's always important to do a CD3 by comparison, and there are lots of T cells as well, because these are infiltrating reactive T cells. And you might say, well, how do you know then that these aren't just reactive? Well, the fact that they're paratrabecular means they're not reactive, okay? And there you're home and dry on that one. We also usually do a CD79A because a lot of the patients, you may be looking at lymphoma after treatment with rituximab, and then the CD20 cells will be gone, but CD79A positive neoplastic cells may still be there. This is CD10, so you've got CD10 positivity in these areas, and if we had the BCL2, it'd also be positive, though many hematopoietic cells are also positive for BCL2, so you have to be careful in interpreting that. So we've got CD10 positivity, plus CD20, so this is consistent with a follicular lymphoma. How do we assess infiltrates within the marrow? Well, again, it's important to have take a wide approach to this. If you've got it, you know, if it's unexpected, this one looks slightly reactive. So what's causing that? If there are lymphoid aggregates, are they intratrabecular or paratrabecular? These are almost always neoplastic. And then to subtype them, I would use these broad panels for small cells, large cells. Always consider T cell NHL in some instances. And then if it's unusual, consider a carcinoma or some other type of cancer, which is, again, highly unusual. So it looks like I'm going to go to this too fast, but I will have time for questions, which will be good. So case 6. This is the H&E. Right, this was a 90-year-old man who had pancytopenia, query hairy cell leukemia. Okay, so let's look at his marrow. So for a 90-year-old, cellularity is probably normal, actually. Maybe slightly hypercellular. So that's one thing about this case, which is probably not typical. He's got a pancytopenia. I don't know what his full blood count was. It's not giving it to me. But for a pancytopenia, you have to have a cytopenia in the erythroid, myeloid, and megakaryocytic lineages. So reduced neutrophils, reduced hemoglobin, and reduced platelets. If you can sometimes get this is a case of myelodysplasia. You can sometimes get a myelodysplasia with just one cytopenia, but they're not going to give you that in the exam. So typically in the exam, you would get a high per cellular marrow and a peripheral pancytopenia. And if you get that combination of a hypercellular marrow and a peripheral pancytopenia, you don't really need to look at the define any more closely than that because it will be myelodysplasia. But what I'll do is I'll try and point out the features that we look for in myelodysplasia to confirm the diagnosis. So first of all, the marrow will be hypercellular, but you can get hypocellular forms, and this is probably one of those. And then when you look at the cells, you'll get myeloid left shift. So we got ALIPs, which are abnormally localized immature precursors in the myeloid series. These immature myeloid cells should be down near the trabeculae. Once they wander off into the middle of the marrow, then they're abnormally localized. That's an immature feature. The erythroid cells are a bit disrupted. So we've got an erythroid island here, but the small, round, dark erythroid cells are also scattered in places on their own. And then the megakaryocytic lineage, you get micromegakaryocytes, and that might be a micromegakaryocyte there. You can only really see them well on CD61, and clustered megakaryocytes. And micromegakaryocytes in particular are good. So, and that's you've got hypolobation here of megakaryocytes. You've got cytological atypia and morphological atypia in the form of clustering. The retic is not particularly increased. Sorry, sometimes the button reverts to the last one. I'll just go through to the CD61. So here are the CD61s. This is a really useful stain, and we use this a lot for diagnosing myelodysplasia because here we've got lots of small megakaryocytes, lots of platelet fragments, a small micromegakaryocyte. And micromegakaryocytes, like here, 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 are not seen usually, and they're not seen physiologically. So if you've got micromegakaryocytes, it's a strong indicator of a probable myelodysplasia. Myelodysplasia is really made, it's a diagnosis made on the combination of clinical and morphological features. If you've got a hypercellular marrow and a peripheral pancytopenia, then you're home and dry. If it's not as cellular, as in this case, then you're looking for more subtle features like micromegakaryocytes, which are best seen with the CD61. And clustering. And then also look to see if there are any blasts. So blasts can be highlighted with a CD34 and with a 117. As I say, you've got to be careful interpreting 117 because the erythroid cells can be positive as well. But 34, we've got quite a lot of 34 positive cells here, estimated about 5% of the cells overall. And that again clinches a diagnosis of myelodysplasia because that's not normal, okay? So you shouldn't really see any of these. Obviously, it's not like that case of acute leukemia where they were all positive, but occasional blasts like this. And again, it is subtle. You've got to look at high power for them. And make sure you don't mistake small blood vessels for these as well, because you get this granular staining around the cells. It could be, that's why it's quite subtle. It's not a complete ring, but granular staining like that there around the cells. If you get those in anything more than 1%, then it's likely to be a myelodysplasia. Okay, so let me just think I'm going to be. So we also look at the erythroid, either using a glycophorin A, which is showing some isolated cells on their own. So loss of cohesion in the erythroid lineage. And the myeloperoxidase shows both densely staining cells, which are the immature cells, and these more granular cells, which are the maturing cells. So if you get a large number of these very darkly staining cells, that indicates immaturity in the myeloid series. Just a couple of things to say about MDS. So MDS, I think for the purpose of the exam, is probably an easy diagnosis because you'll get a hypercellular marrow and a peripheral pancytopenia. But what you're looking for is cytological evidence of dysplasia, so abnormal erythroid features, which are mainly seen, in fact, on the aspirate, and it's a combination of an aspirate and fine diagnosis. So high numbers of megakaryocytes, hyperlobation, micromegakaryocytes, and then in the myeloid series, you get immature myeloid forms and also left shift. And then it's also not just cytological changes, but architectural changes. So immature myeloid cells away from the trabeculae, clustered megakaryocytes, and discohesion of the erythroid islands. And then in terms of, it can either be defined with genetic abnormalities, but obviously you're not going to know that in the exam unless they give it to you. And if it has got a genetic abnormality, again, it clinches it as an MDS, or morphologically defined, and then it's either myelodysplasia with low blasts or myelodysplasia with increased blasts, which is either 1 or 2. 1 is up to 10%, 5 to 10%, and 2 is 10 to 20%. And once it's over 20%, it's acute myeloid leukemia. So I'll go on to case 7. Yeah, so case 7, it was this is a 45-year-old woman with a high platelet count. So high platelet count, something like 700, 800. You know what the diagnosis is. You kind of don't even need to look at the slide. It's going to be essential thrombocythemia because, as I say, they're not going to give you really difficult cases in the defined section if you get it. And it will be a long case if you get it because they'll have to give you the retic, the immunos, and so on. Because if it was really difficult, they give you so much information, you would not have to look at the slides. So setting Trefine cases is actually quite difficult for the exam because you have to find really classic cases that are simple. Otherwise, you don't, like I say, you just read the history and there you are. So this case here, it's not as busy as the other myeloproliferative neoplasm we've seen, but you can see we've got some abnormal megakaryocytes. They look cytologically abnormal. We've got small little clusters. These look abnormal here as well. Got a little cluster here. And got another little cluster there. So if we look at the CD61, so the retic is not increased. And the cellularity is not increased. So that's important. So in essential thrombocythemia, the cellularity and the retic is not increased. In polycythemia vera, where you get high hemoglobin, you can get increased megakaryocytes, but they tend to lie singly, and the marrow will be hypercellular in general, whereas in ET, the marrow is usually normocellular. There's the CD61. So this highlights the clusters of megakaryocytes. And you can see that the clusters are slightly looser. They're not as packed in as in that first case of myelofibrosis. It's not usually difficult to distinguish, early phase myelofibrosis from essential thrombocythemia because megakaryocytes will look different in myelofibrosis. The clusters will be larger, the cells will be more pleomorphic and bizarre. Of course, you can get myelofibrosis emerging out of essential thrombocythemia. I don't think that they'd give you that in the exam, except if you got a case of clear myelofibrosis and it said in the history previous essential thrombocythemia, and then well, whatever form of words, they probably wouldn't penalize you if you didn't get the exact form of words as in the WHO, because it keeps changing all the time. I struggle to keep up with it. But if you said essential thrombocythemia arising in a background of myelofibrosis, sorry, myelofibrosis arising in the background of essential thrombocythemia, that would be sufficient. What can I say about that? Otherwise, I don't think much beyond what I've already said. So I think I will stop all shares now and take the questions in the remaining 3 minutes.